Okay, hi everyone that's joining now. Welcome to this FCI webinar on the Core Competency Framework. We've got people still joining at the moment. I've got the FCI webinar housekeeping slide on the screen at the moment, which hopefully you can see. Just if you could keep yourselves muted during the presentation, and then you can unmute yourselves during the Q&A section at the end. There's some keyboard shortcuts there for muting yourself. Please do ask questions in the chat bar during the presentation, and we'll get to them at the Q&A. Hopefully you can all see the chat bar. We have had some feedback previously of people being unable to access it. This may be to do with if it's on your desktop app or the web app, and I think in terms of browsers, Google Chrome and Microsoft Edge are often the best ones, apparently, in terms of functionality, but hopefully you can all see that. And we are recording at the moment as well, so this will be uploaded to the faculty website and YouTube channel after the webinar to watch back. And yeah, I think that's everything for now, so I'll hand over to Alan.
Hi everyone. Thanks very much for coming along to find out about the Core Competency Project. Can we have our first slide, Joe?
Yeah,
is that okay? I'll just introduce myself and then ask Prof. Georgina Moulton to do the same. So my name is Alan Hassey, GP by background, donkey's years in clinical informatics, including spells in NHS Digital and working for the National Data Guardian. I have spent 2 years now on the faculty's Core Competency Project in my capacity as chair of the FCI's Education and Standards Standing Committee, and we delivered the reports and the competency framework with our partners, the University of Manchester, just over a month ago. And this is the third opportunity we've had to present them. So I'm going to take you through the early stuff, our phase 1 work, and then come back a little bit later to talk through the implications of the project and taking it forward. And George Moulton will take you through the academic aspects of the project. So, George, do you want to say hi?
Thanks, Alan. Hello, my name's George. I'm a Professor of BioHealth Informatics and Education at the University of Manchester. And my main role is to do training, learning and development of informaticians and health data scientists. My background is in originally bioinformatics, but over the 15 years that I've been researching and doing workforce development, I've moved further into doing health and public health informatics too. So thank you very much, Alan.
Okay, next slide, please, Joe, if we could. So this is just what we're going to do. These sessions are much more fun if we don't bore you to death with PowerPoint. So we'll try to make it as interactive as possible. And Joe's promised to keep an eye on the questions, which we anticipate will pop up on the chat line. And we'll do our best to answer them. So I'm going to take you through Core Competency Project Phase 1, starting now. So next slide, please, Joe. So the Faculty of Clinical Informatics is just over 3 years old now. And when we were established, we had 2 overarching aims, which were firstly, to develop professional competencies for clinical informaticians and to provide accreditation for informatics-based training programs. So the way that we decided to address those overarching aims was to establish a project, the Core Competencies Project, with the following aims. So it was really looking across the whole of the UK, but very much a 4 nations body, and it was to develop, test and define the core competencies required of a professional clinical informatician, define the core skills, knowledge and traits that constitute the core competencies, and develop a process for accrediting informatics educational applications against that competency framework. Now, core in this context denotes the minimum knowledge base that all clinical informaticians must have, that we would regard as being the basis for ultimately for membership of the faculty. So it isn't really about what do you need. It's not looking at the subspecialist avenues of education, so for nurses, pharmacists, doctors, and so on. So we'll talk about that in a little bit more detail. Next slide, please, Joe. So we did run this as an academic project with input from Lydia Jidkoff, Trish Greenhalgh, and Georgina Moulton. So all of these academics were able to provide, as you can imagine, some pretty robust challenges to the methodology we proposed, and in George's case, to take it on and develop it further. So we worked very closely with the University of Manchester in this project, and they've been key partners throughout the work. So we within the faculty, we undertook phase one, and that was looking at defining output competencies that we expect of care professionals working as clinical informaticians. So there is in the next bullet a sort of definition of what competences mean. So we derived this again from work undertaken previously by Trish Greenhalgh, and output competencies are those things that are achieved in doing the job. In other words, this is all about what we do and who we are. So the outputs from phase one of the project would be used to inform and underpin phase two, and that would be the competency framework led by George's team at Manchester. Next slide, please. So phase one was undertaken by a team which started work, as I say, over 2 years ago, and we presented the findings as 3 linked reports. It's really important to understand that when we started this, the membership of the faculty was just over 100, and the latest recruitment round is likely to mean that by tomorrow, which I think is tomorrow the date of the next announcement about new members, will be over 700. So it's been really a key part of this process to test, iterate, develop, validate the findings and at each stage back with our membership, because that membership is A, much bigger, and B, more diverse than it was to begin with. And what we've looked to develop is one overall competency framework for clinical informaticians and clinical informatics. So the first part was a discovery stage based on conversations and looking at definitions of clinical informatics and clinical informaticians that we tested. And we came out of that with some early principles, themes, areas, and attributes that kind of we hoped would set out the basis for describing who we are and what we do. The second part was a validation study, looking at draft output competencies in the form of semi-structured questionnaire. Again, this was tested back with the membership, a deliberative sample, making as sure as we could that we were checking the work that as we were going with a sample of our members that was broadly representative at that time. And it was really interesting what came out of that. And we also tested some of these with members of the public, see what they thought of it. But really interesting that quite a lot of people who were very clearly clinical informaticians were reluctant to identify themselves as such. And we think partly that's because some of those skills that many of us will have in terms of areas of activity such as patient safety or information governance were not regarded by some as being adequate for people to describe themselves as clinical informaticians. They felt they should have hard coding skills, either as in the sense of being computer or data scientists, or a detailed knowledge of coding and terminologies, for example, SNOMED. So what we did was develop the early principles and attributes and areas in terms of statements to be tested again, which we did in a consultation stage of the first phase. And this was an exercise which was open to all the members at the time. And it was an online survey testing 7 statements. We had 118 responses to that from 21 organizations and 97 individuals. And at every stage, actually, we received lots of helpful comments, but a remarkable amount of support for the findings and recommendations that came out of the earlier work. So just to say again that this was a work where we iterated, tested, sampled, and validated in an iterative way to build up our confidence in the findings. So I think that's really important, and was important in underpinning the work that George will talk about in phase 2. Next slide, please, Joe. So the 7 statements, I think the first 3 are probably the most important. So we've gone for statement 1 is clear and I think is obvious to all of those of us who are members or fellows of the faculty. It just sets out that what is a clinician and how can you be regarded as a clinical informatician in terms of becoming a member of the faculty. Statement 2 and 3 are not definitions. We avoided definitions for the reason that we felt that they were exclusive. And what we wanted to be was as inclusive as we could be. So we framed them in terms of statements that are descriptions rather than definitions. So these descriptions are for clinical informatics and a clinical informatician. Next slide, please. And this principle of inclusiveness is actually highlighted in statement 4. And really important that we are and it came through very strongly from the feedback from our membership that they saw themselves as players in a bigger team, collaborators, cooperators, and leaders, working with other social care professionals, other non-registered informaticians, and of course patients and families. Now, statement 5 and the next slide, Joe, 6 and 7 set out the principles, areas and attributes of a clinical informatician. So these are the kind of things that help to differentiate someone who is a clinical informatician and describe those areas of activity. And it was very, very clear, and I'm sure George will pick this up as well, that the themes around clinical safety, leadership, were really important, as well as aspects of governance. And so these are set out in more detail in our reports, and you can, if you want just a summary of them, they're in the summary report for the whole project. All of these are online. Next slide, Joe. So, just to sort of wrap up where we were with phase 1, we explored, validated and consulted on what clinical informatics is and who we are. And we've set that out in detail in our phase 1 report. We think that met our first key challenge, so that we are able now to describe confidently who we are and what we do. And we've set that out as a set of statements. And they're available, as I say, on the website. Next slide. Thanks, Joe. And the Core Competencies Project is an important part of the work of the faculty, and the reports and the framework that were, and all the work, particularly around phase 1, phase 2. There's some of the phase 3 stuff there, but we'll come on to that a little bit later. It's all available from the top of our homepage. Next slide, please. And at this point, I'll hand over to George. So everything we did was to inform George's academic approach to developing a competency framework. Over to you, George. I'm going to go on to mute now.
Alan, so I think for me, the importance of Alan's work was that it allowed us to understand what the community, how they define themselves, and the areas that were key in clinical informatics. The approach that we took then using this information was to then use a mixed methods approach to develop the final core competency framework. So could we just move on the slide, please? So when we spoke about clinical informatics, we took a broad approach to this. So we looked at anything from clinical informatics, nursing informatics, pharmacy informatics, right the way through actually to clinical scientists who are under Professional Bodies Award and who are more bioinformaticians. So it was a broad approach that we took to the development of this framework. The slide in front of you will show you the stages that we used to develop the framework, and it was really done in 2 main stages. The first was to create a strong evidence base to provide the first draft of the competency framework. And that evidence base was really a systematic review of all literature over the past 5 years. And the second bit was a content analysis. So really looking at current job postings in the area, so of clinical informatics. Once we'd established that strong evidence based and we looked at already existing frameworks, some of which I developed myself, and existing curricula, we then were able to draft that first competency framework. Now that was very much a theoretical framework based on experience and based on that evidence base. What we wanted to do then was to test that with the community and understand whether that matched against the roles and expectations that they were doing on their day-to-day roles. So we then performed stage 2, which first of all was interviews, semi-structured interviews, which really were to delve deeper into what people thought of the core competency framework, and I'll describe that later. From that, we refined the framework, and then we sent that back out to the wider community as a survey, again to elicit comments and modifications. And after that survey, it then was finalised the framework, and the publication that you see on the website is as a result of all these stages. So could we move on a step, please? So stage 1 was the systematic review. It's been published in the International Journal of Medical Informatics. And the key for this was that we wanted to, like I say, identify what the key themes were and to marry up with what Alan had found in phase 1. So we took several search terms, clinical informatics, pharmacy informatics, bioinformatics, and we scraped the literature. In fact, there were 13 terms in total. And we wanted to ask really 2 questions. What are the common skills and competencies that are being identified? And then the second question, which was, do they vary? So do these skills vary by level or by type of education or training or background? So as a result of this search, there were just over 12,000 publications that we then identified. And once we'd done the filtering process, we found that there were 8,000 unique ones. We did a full systematic review. So these were then sorted and filtered by 2 different coders, resulting in 311 text papers and then 82 that we took through to final review. So it was those 82 final papers that we based the identification of the areas for the core competency framework. Could you move on a slide, please? So from these 82 papers, we identified, as you can see here highlighted in red, 5 core areas. And these really nicely mapped onto that was found in phase 1. So data, information management, human factors, project management, and I'm just, sorry, I can't see the last one. And this really did start to sift through then what skills were important to each of these identified areas. So as you can see in data, what you can see here are the different skills on the different areas that were highlighted in that data category. So, and the number of papers that mentioned those particular areas. So statistics, modelling and simulation were mentioned the most in the data category. And again, those regulatory frameworks and policies required to work with the information were highlighted as being important. And as you can see here, the data and the information management are where most of the papers started to mention those skills and competencies. However, and I do stress this, that the things like human factors, project management and leadership are all equally as key to the competency framework, and we took that message forward. So here we were allowed to see the distribution and also the key areas for that competency framework. Next slide, please. So this produced the outline of the framework for consultation with the wider community. And the first thing that we did was to go to interviews. We conducted these in a semi-structured way with 15 participants. And these 15 participants were chosen by the faculty membership. And they were involved in various aspects of informatics. So not just clinicians, but there was also people from biomedical backgrounds and software engineering. So it's more on the software engineering phase. And we wanted to understand more about their role and how that could input into the framework. So we had identified areas of importance and skills. We wanted to know how they were being used in the wild, so to speak. Here on the slide, you'll see that a diagram that shows you kind of the types of areas and comments that we were receiving from those 15 participants. So on the left, you can talk about the framework composition, and the themes that arose were actually what was the target level and granularity. So people were starting to eke out the balance between technical and clinical expertise and skills. We asked specifically around what competences were missing. And again, I think here at this stage, a lot of it was around governance and regulatory and security and the interoperability between systems. It wasn't that they weren't mentioned. I think it's people wanted to see more of a mention of these areas. We also could see that the language and terminology is key to competency frameworks. Again, we wanted to make this health and social care, and it's very easy to slip into language that would focus mainly on the health sector. So again, we were changing language around the health and social care workforce. On the right-hand side, the people were really helpful in making specific changes to the framework. And mostly those we asked around, did the structure make sense? So the structure that you now see actually is the one that did make sense to people. So understanding about the data and then in the information systems to influence decision making and how you would lead those projects. And then the final thing was the changes to the competencies. Some people were really quite clear on the changes that they wish to be made. So around introducing particularly areas more around the analytics, for example. The next stage, please. So those interviews were also taking place in the broader context of us understanding more about the roles and the tasks that people performed. And that then resulted in version 2 of the framework. So that integrated that task-based analysis. The final stage for us was then to go out to survey, and this was to really hear from the wider community about the framework. It went out to FCI members, amongst others, and we got 87 respondents. Out of those 87 respondents, most people identified as clinical informatics backgrounds. The next were public health informatics backgrounds. So those two made up the majority of the respondents for the framework, which was good. And this survey was constructed using 12 main questions. And the first 6 questions were really focused on how well do you think these competencies match to the UK and the tasks that you do? What is the representation of skills? That's question number 2. Question number 3 was the balance, again, between clinical and technical areas, always a difficult one to contend with. 4 was the understandability. So when you read something in that framework, were people able to interpret it and use it? 5 was about the present, how it was presented, and 6 was how many do you think you currently cover in your job? Now, as you can see here, the diagram on the right-hand side just shows you the results of those different questions. And we found that most people found that things were positive, so that it was understandable, people could relate to it, and it was representative of their skills. So you can see the skew towards scores 4 and 5. Now, the next set of questions were really, again, to elicit an understanding of whether this matched onto what people expected. So again, this was, would you suggest any changes to the terminology? Do you have any comments about the overall structure and the individual components of that framework? So this was very much a space for people to be able to comment freely on what they saw as a competency framework. Now, again, I think if we were to look at the areas that were at this stage of improvement, it was more around the changes to some of the wording of the competencies that we focused on, and making sure that they did follow that structure that Alan mentioned in phase 1, of that there was an input, the process, and the output. So we made that very clear, and that's where we made most of the changes at this stage. There was also still a suggestion of new competencies. Now, one thing I will add here is that when I first drafted the framework, it was 66 competencies, and it's very difficult. You don't want something to balloon so much that it becomes difficult to maintain and difficult for people to be able to achieve, especially as they are core competencies. But what we did find at this stage, that the suggestion of new competencies were really quite useful in unpicking some of those competencies that were perhaps at a higher level. And so the suggestions here were particularly around the clinical safety aspects of things, and the context of which you operate. So again, the information and the data we did mention in sufficient detail, but people wanted to see more about the impact that would have and the context in which you were working as clinicians, clinical informatician. Also, what we found at this stage is that people did find this aligned well with other international competency frameworks. And we obviously had taken that into consideration in the first drafting of the framework. So people could then see that this was comparable to other frameworks that were in existence. I think what I'd say at this stage is that we found this the most useful stage of the framework analysis, because people were able to provide that detailed feedback in those last 6 questions, and we did listen very carefully. So I have a notebook and a mapping of all the suggestions, and those that we took forward and those that we didn't at this stage. Next slide, please, Jo. So this is the framework, and the framework can be constructed in many ways. This framework was constructed using Bloom's taxonomy, which many of you may be familiar with from a more academic background. But Bloom's is very good in that it starts to identify and show the level of understanding that an individual needs in order to be able to complete a competency or an objective. So Bloom's starts at level 1, which is the very basic understanding your knowledge and your description and identifying things. And level 2 is about whether you can understand something. So whether you can start to talk about it in a little more detail. Discuss is usually the verb that is used. Right the way up to level 6, where this is very much around evaluation and appraising something, being able to justify it, and that's using that knowledge. It's so that you are able to drive things forward in your own environment. So we constructed very much that framework based on Bloom's taxonomy. And what you can see here is the left-hand side is you can see the different frameworks areas, and those did map onto the areas identified by the systematic review. So it's health and well-being in practice, information systems and technologies, the working with the data and the analytical methods, and then how do you get people to change, both as individuals and organisations, and then how do you lead informatics teams and projects. And that diagram on the left is the thing that we set the domains that you now see as the framework. So the health and well-being in practice is domain 1, and it goes around in increasing order clockwise. So we use those domains. So there are 6 domains. There are also 111 competencies for the final framework. And many of them do relate to one another. So once you know one in a particular area, let's say change management, it will be very easy to complete another framework. So some of them, another competency rather, so some of them are linked. And you can see those in the different categories underneath those domains. So each domain is separated into categories. What you see on the right-hand side is the distribution of Bloom's taxonomy levels. So what pieces of feedback that we got were what is the level and the target and the skill that we are required in order to complete these core competencies. And what's good is that if you look at this graph, is that you will see the most of the Bloom's taxonomy levels are at level 1 and level 2, which means that you are able at this stage to know something or understand something. And we've given an indication of where you could apply it, but most of it is written at those lower levels of Bloom's. In some instances, we have made pushed that up to higher levels of Bloom's, but those were based off the tasks that people were regularly doing in their day-to-day job. So that's when we were able to say, actually, the core competency, you do this on a regular basis, and this is something that you would need to apply on a regular basis. And another interesting fact here, is that the domain 2, which is the information systems and technologies, that's where most of the competencies do lie. And it was interesting because you try to get a balanced approach to the different domains and the number of competencies across those domains, but really listening to the feedback given by those 2 stages, it did show that main area, the information technology, where the most competencies lie. So it is interesting to still see that when you see this diagram in front of you. What I think in the next slide, please. So the core competency framework that resulted from both of those stages is available on the FCI website. You see this as in the domains, and then here you'll see the categories, and underneath each category, so here informatics strategies, you will see the individual competencies that one would need to complete. And these, like I say, there are 111 of them. There's still some debate whether people need to know all of them. I think you do. It really did strongly come out of both of those stages that these are the 111 areas that people would need to know, at least know about and understand, for them to be able to function as a clinical informatician. And I'm just going to say there's been also a lovely mind map of the competency framework produced by somebody that is also very useful to be able to conceptualize this framework in a different manner. But thank you very much.
Next one, please. This is just a little bit of, we won't really cover this in any detail, but we're in phase 3 of the project, was really about accrediting programs, courses, and against the competency framework. I'm going to move fairly quickly on because we're getting some great questions, and I really want to shut us down and open the conversation up. So next one, please, Joe. It's really important to think about the competency framework in terms of what our members tell us that are the most important things. And the feedback we've had from members this year has highlighted these are the areas that are the most important to them. So you can all read those, I won't go through them, but they therefore need to be taken into account in thinking, how do we take the competency framework forward? Next slide, Joe. So what we've done is begin to set out how we will use the competency framework, and we've begun to think about that in terms of how it will be useful for organizations, so courses, qualifications, for employers, to support CPD, professional appraisal and revalidation, and to think about a standardized approach to the specialism of clinical informatics at all levels. Now, what we have not said in the core competencies is at what stage of an individual's progress through their career they should acquire these competencies. Some of them, I think, very clearly are undergraduate, and some of them are postgraduate. Clearly, this is an area that's important to think about in terms of an income stream for the faculty. We're still a very embryonic body, still relying on external funding to support us. And we really have to look to stand on our own 2 feet and think about how the project output can support the faculty business plan. Next one, please, Joe. And so we also need to think about the knowledge and skills that individuals need to acquire to become and to develop as clinical informaticians. So, and to accredit individuals. So how can individuals develop a portfolio, for example, of evidence of competencies to support them in their career progression as clinical informaticians? And the bigger question of how do we represent ourselves and take this forward in discussions with stakeholders. Next one. Joe, please. So the way we've started to address this is through a competency framework working group. We invited we invited people to say whether they'd like to work with this group, which sits within the Education and Standards Working Group and reports to FCI Council. And what we're hoping is that this group, a multi-professional group, will highlight the key areas that need to be addressed to take this forward, to take the competency framework forward on a multi-professional basis, thinking about areas like membership, professionalism, mapping of job descriptions and role descriptions, accreditation and certification of courses and course providers, and a review of learning requirements and provision. Next one, please, Joe. There might not be a next one, which
yes,
might
I think that might be the end.
Which might be great to take us back to the beginning.
Sure.
so that we can begin to throw this open to questions. Now, I've spotted two, one from Andrew Winter. Andrew, do you want to come off mute and maybe just talk, just ask your question yourself rather than me read it?
So Landis, I posted a link to the Future Health Channel. There's a lot of interest in this, and I think COVID has just really put this forethought. And we had a really successful event in our own board with 100 people just dialing in yesterday to Teams for 2 hours to look at digital innovations. And I absolutely pick up your thing about people not knowing that they're digitally competent clinicians, and this framework gives them a thing to do it. But how do we get that into visibility? So one of Amit Banerjee's articles is about how do you make this the new normal? We cannot allow our doctors of the future to come out without at least some of these competencies. And how can you say, well, these are what you should have at a certain stage of, say, I'm a physician, so medical training, and work them into the curricula of the Royal Colleges, which is how a lot of the medical training is managed. It's obviously a overtly medical approach. We need to do the same for the other specialties as well. But I think particularly for the medics, you've got a structure with very clear curricula and a very similar approach to what you're doing with the different level descriptors there, which would fit very nicely into that. And a lot of them have space for generic competencies. They normally say, skilled in using Office and able to audit using an Excel spreadsheet. That's the level of competence we expect a kind of person who's going to go into an 80,000 a year consultant job to have in 2021 or 2022 right now in my current specialty.
Yeah, well, I mean, I think it's a great question, and it's a major challenge for taking the competency framework forward. So it's actually taking it out of the theoretical space and doing something practical with it. So some of the difficulties that we have, I hinted at earlier, which is that we haven't said at what stages different specialities need to acquire some of these competencies, and some I think are very clearly at the undergraduate level. And if you think about it in terms of Bloom's taxonomy, many of those things around just familiarity with records and records governance, for example, you would expect people to be acquiring that kind of stuff from a medical perspective as medical students. But some of the more detailed knowledge in the same area might be for an organizational Caldecott Guardian. So a area around records governance. So I think what we have to do is begin the conversations with, for example, the Royal College of Physicians, and we have done that, and with professional regulators, the GMC. So that's on our list to do. And it's definitely identified as a task to be addressed by the Competency Framework Working Group. Now, just to say again that as we do this work, we'll be talking to the membership the whole time. So one of the first tasks of the Competency Framework Working Group is through, we've lost all the pictures. Oh no, we've got the slide back. Joe, we have an article coming up, I think, very soon, describing the work of the Competency Framework Working Group. And as we do that, and our members hear about it, this is, again, not an exclusive thing. It only works it works better if our members talk to us about it. So, Andrew, I'm hoping that you will give us a steer. This is not a top-down project. At every stage, we've relied on our memberships to steer and guide us. George, you in one of the papers talked again about different competencies for different types of clinical informaticians at different stages. And we kind of said that defining the different stages that people would need to acquire these skills, that was something for another project. Do you have anything you'd like to add to what I've said?
So I think you're right. Some of the skills can be picked up earlier in one's career, and some much later. What we did find from the systematic review is that we started to see there were two things. One is the level of skills and knowledge that one would require much earlier on. So nursing, for example, some of their competencies were coming in at undergraduate level. and then those that you would acquire later on. So we started to see the graduation of where somebody could pick that up. The other signal that we picked up was we took a broad approach for who was going to be in the clinical informatics family. There were nuances and differences between people with different disciplines. So, for example, medics require something slightly different to nurses, for example, and all actually the allied health professionals plus medics required something different to a bioinformatician, for example, because there was definitely a specialist skill set for bioinformaticians. So I think this is a piece of work that certainly I'd love to continue based on that systematic review, in starting to be able to say at what stages and what is relevant perhaps for each of these different informatics backgrounds.
So Andrew, so we can move along, would love you to, what do you think we should be doing? Please tell us. And if you can't summarize it in a sort of in 30 seconds or a minute, then email us and tell us. So we'd love to hear from you.
So I haven't been myself closely involved with some of the curriculum, but my colleagues have, and I've been watching it. So I think it's about getting the language that you can use. For example, I look at my own curriculum here, and it says basically just says local and national databases. That's all they could think of. That's the phrase they used, and we have to judge trainees as to whether they can or cannot understand what that means. So it's about using little short phrases that they're in the language that JRCPD use and they're familiar to them, at the level descriptors. And injecting them in and say, well, rather than having sort of explaining data protection for information legislation, that's a knowledge step. What's the next level we want to get to, and challenging them. Now, the problem is there's 30 odd plus medical specialties, but they often have a common language set around these kind of management and leadership issues that we could begin to inject in. And the curriculum under review, they go around in cycles. So it's a case of engaging with JRCPD for physicians. I'm sure surgeons have similar stuff, and try and move people thinking on from audit and looking at a database to understanding digital. None of them say digitally competent or literate or able to use Citizen or understanding cybersecurity. But I think, when you're running a service now, you need to really be aware of these things at all levels of medical practice.
So
okay. Yeah, go ahead, George.
It's an interesting discussion because we did a survey, it'd probably be 3 years ago now, around clinical undergraduate medical trainees' understanding of clinical informatics, and did they understand that it was a role, and actually this was for year 3 and year 4 medics. And then we started to ask them about electronic health records and some basic understanding what knowledge they had, and it was very low, even at 3 and 4. And I think you're right. It does need to be integrated into the curriculum at undergraduate level. So, for example, at Manchester, this is something that we are looking at, and I think there's room here to start to be creative about how we can include some informatics in other areas of the curriculum. So sometimes it's there's too much in the curriculum, but I think I've started to try and create a narrative through what's already being taught that would introduce different elements of informatics. But I think I do take your point around what's ready and what's available for undergraduate medics.
Okay, can we move on? Jeremy, great challenge. Do you want to ask your question, Jeremy?
Yeah, thanks, Alan. So I'm increasingly coming around to think that psychology is the fundamental science of computing and information technology, because after all, the vast majority of information systems are designed to produce information to support human decision making and human action and behavior change. And therefore, anybody who develops or procures these information systems really needs to have a very good feeling for how humans make decisions, communicate, and change their behavior. And there's now a great deal known in psychology from, for example, Tversky and Kahneman's heuristics and biases around decision making, to Susan Meek's typology of behavior change techniques, if you're trying to get people to actually change their behavior. as well as risk communication, framing effects, etc. Now, those, if you like, are theoretical backgrounds and knowledge that could help clinical informaticians understand what's good and what's bad about information systems and how they can be improved. But they don't seem to appear explicitly in the competency framework. There are things like risk communication and behavior change, but for example, on the behavior change bullet point, there really isn't any mention of behavior change techniques or the COM-B framework. So the question is how that understanding of human psychology and the theories, if you like, explicit understanding, well, an implicit understanding that we'll have, contributes to being a good clinical informatician. I'll stop there.
George, do you want to comment on that? And I've got a couple of things just to add, but anything to say about that in terms of the framework?
Yeah, I think so, Jeremy. I mean, I read it with interest, and I think you're right. So there's lots of literature and knowledge that underpins. Well, if we were to take that competence, it's kind of implicit. But the other thing that I did find when drafting it was, for me, a clinical informatician is the glue as well. So you would be working in teams and using knowledge and expertise from others in that team. And I think so part of it, and I will say this, is that I think you would be working with others that would be experts in human psychology, and we're using that expertise in order to do the procurement or implementation of digital systems. And that is the position I would take on that. But I do take your point. Yeah, it's not explicit in that framework, but that's the reason why.
Yeah. So Jeremy, I would say the framework I regard as being a fourth road bridge job, that we have version 1, and in 2 or 3 years time we'll have version 2. So if there are gaps, and no, not if there are gaps, there are gaps, of course there are, please tell us what they are and tell us how to fill them, and tell us how we can make it better. That would be extremely helpful. So we are always up for robust academic challenge, which is why we drafted in. You are also a key academic in this field, so please challenge as much as you like, and also help and guide and steer. That would be incredibly helpful. Thanks.
So can I just?
I think there are some hands up as well.
Yeah, Leslie has a hand up.
Did George just want to add anything there?
I just wanted to add, I think, Alan, that's a really important point to make, in that this is a version of it. I don't see competency frameworks to be, it should be a living document in many ways, and go under an annual or biannual, not biannual, two yearly process of review. I think that's really important. So that it keeps up to date and that everybody's still it's still maintained properly. And so that's one thing that we did recommend, and Alan has picked up on, for keeping the document up to date.
Joe, have you spotted any questions I've missed or hands up?
Yes, Leslie Kay's got a hand up if she wanted to come in there.
Yeah, I just wanted to comment. So I've got the honour, privilege and terror of leading the introductory session in the Newcastle course that Tej Al-Shah is organising, starting next week, aligned to the competency framework. And I will be largely concentrating on leadership and change management in that introductory session. And we're doing a section on Carla's behavioural drivers. So I think it may not be explicitly spelled out in that section, but it seems to me to tie in very well with the leadership and change management competencies that have already been identified. So I don't think it's missing. I think that it's perhaps not all completely spelled out, but that's the nature of a new curriculum, I guess.
We are getting, we have 2 definite academic partners, University of Wales and in terms of course development, and University of Newcastle. Be no surprise that we're also going to have conversations with the University of Manchester. So I think in terms of turning these in, the framework into something that looks more like a curriculum, certainly the Cardiff work is building towards a master's degree. So I think a lot of these things will come out and will require amplification in terms of notes, Jeremy, that we need to provide to the competency framework. And I think it will, I don't think piece of work, and look forward to your input guiding and steering us. Thank you very much. Any other questions? I have responded to Annie and Alicia. Do you want to say anything about nurse AHP perspective on the competency framework?
Hi, yes. It was just to really flag the fact that I did some work for Suzanne Rastrick about 18 months ago, and it really flagged that there's a massive ambition with AHPs around the sort of informatics agenda. But I think what we felt was that there was quite a significant gap between AHPs and nursing. Obviously not the two interchangeable, but we quite often get linked together just for convenience quite often, I think. But there really is a massive interest for AHPs. I'm an occupational therapist, and I'm leading a project at the moment around this. But I think there is a real opportunity to engage AHPs much more specifically. There's 14 professions.
We completely agree.
So yeah.
Yeah. So there is within the faculty, I don't know if you know, there is a nurse AHP. What Joe, are they called a special interest group or
a professional interest group? We're calling it at the moment. Yeah, so it's getting itself going.
Yeah, and we have again we go out to build groups that are broadly representative of the membership, and the competency framework working group has representatives from nursing and AHP and pharmacy and medicine. So all of those groups are in there and very vocal already. So the AHP voice is definitely being heard. But hold us to account. Make sure that what comes out of it looks sensible in your context. Don't hesitate to tell us what you think. It's really important you do that. Anybody else got any questions for us? Or have we stunned you into silence?
We did have a comment, Alan, from Robert asking about it'd be interesting to see a Venn diagram mapping of core competencies of professional groups, which may be part of the further work Professor Moulton is talking about. Robert, if you're there, would you like to ask your question?
Yeah, it was just really thinking about how much this is part of a team effort, and Georgie's comment about you don't need to know everything about psychology or change management psychology. You would. It's about knowing that you need to pull that expertise in, and that got me thinking about when we're looking at developing the education programs that will fit people so that they match the core competencies. It'd be interesting to see quite how much overlap there is, and I suspect what we'd see is a map where there was the Venn diagram. There was an awful lot of common competencies that are being developed by the professions, and it's where each profession would need to top up. That would be a really interesting thing to look at. Thank you.
George, want to say anything?
I mean, that's something I would be terribly excited to do. I think it is required, and it's understanding, what the different roles need in terms of is it proficiency or is it, just basic knowledge. I think it's that it's profiling the team, and it's very interesting to do. I've started to do that for health data scientists, which is slightly different, but yeah, I think it is the next piece of work for sure.
That's interesting. My background is healthcare science, so if there was anything I could contribute, I'd be very happy to join in.
Anything else, Joe? Anybody else? Anything to say?
I think we've covered most things. Andrew's mentioning HEPMA, Hospital Prescribing System. But I think in terms of questions, we've kind of we've covered most of them, unless anybody has any last burning questions or anything.
Okay, just to finish then, just to reiterate that this has been built on validation by our membership. That process goes on. You hold us to account so that this competency framework reflects the kind of clinical informatics that you do and the kind of clinical informaticians that you are. If it doesn't, then you need to tell us so that we can change it and get it right. I don't know whose phone's ringing. Oh, it's me. Get rid of my phone. Anyway, thank you all for attending. Some great questions, and if you've got any more, then please contact us through Joe, and we look forward to reporting more through the usual faculty channels. Thanks very much from me, and thanks George for I think this is our last joint presentation, but thank you very much for all your hard work with the faculty. We really appreciate it.
Thank you.
Joe?
Thanks all.
Yeah. Thanks, George. Thanks, Alan.
Bye.
Bye now.